When we think of modern psychiatric medicine, we usually picture these incredibly complex molecules.
Right, yeah. Like pristine laboratories.
Exactly. Teams of scientists in pristine labs using, supercomputers to design these hyperspecific compounds to target exact neural receptors. It feels very well like high-tech molecular engineering.
It's entirely built on a philosophy of precision.
Yeah.
I mean, the driving idea of modern pharmacology is basically finding the exact lock in the human brain and then forging the perfect chemical key to fit it, and literally only it.
Right. But then you look at one of the most complex, difficult to manage psychiatric conditions in human history, bipolar disorder.
Mm-hmm.
And you look at the most effective treatment we have for it, and it completely breaks that whole modern engineering narrative.
It really does.
Because the treatment isn't a complex molecule at all. It's an element, a basic metal ion right off the periodic table. Stardust, essentially.
It is, yeah, the ultimate paradox in medicine.
So for today's deep dive, our mission is to synthesize clinical pharmacology, a bit of wild medical history, and, cutting-edge research to understand what we call mood stabilizers.
Right.
And we are zeroing in on the undisputed, undefeated king of them all, which is lithium.
And I am so thrilled we're tackling this. Because if you are listening to this right now and thinking, wait, isn't lithium what makes my smartphone battery catch fire?
Yeah, literally.
You want people to ingest that? Well, you aren't entirely wrong to be skeptical.
Exactly that. We're going to take you through a story full of bizarre, accidental discoveries, long-lost medical mysteries, and honestly, life-or-death stakes. I promise, by the end of this depth dive, it is going to completely change how you view psychiatric medication.
For sure. And let's start by dismantling a pretty major medical misconception for you right off the bat.
Oh, please do.
And that is the term mood stabilizer itself. Because, to understand lithium, we first have to understand the landscape it actually operates in.
Okay, let's unpack this, because if you look at a textbook or you hear a psychiatrist use the term mood stabilizer, it sounds like a very specific class of drugs, right?
On the assumption, yeah.
When I hear it, I assume it's like saying antibiotics or, beta blockers, like a group of drugs that all share the exact same chemical mechanism.
Right. But the reality is there's actually no formal FDA category called a mood stabilizer.
Wait, really? None at all?
Nope. It's entirely a functional myth, at least as a chemical classification. The term is really just clinical shorthand.
Oh, wow.
Yeah, over the decades, it just sort of got slapped onto a bunch of chemically unrelated medications simply because they happen to calm patients down.
I mean, just looking at the list of what gets called a mood stabilizer is baffling. You've got lithium, which, again, is just a metal ion.
Right.
Then you have drugs like valproate and carbamazepine, which are actually seizure medications, right?
Sure.
Anticonvulsants. And then there are modern atypical antipsychotics like quetiapine or olanzapine. Chemically, they have absolutely nothing in common with each other.
Which created a massive amount of confusion in psychiatry. I mean, if everything is a mood stabilizer, then the term means nothing.
Yeah, it loses all meaning.
So in the early 2000s, two prominent psychiatrists, Terence Ketter and Joseph Calabrese, decided to actually try and formalize a definition. And they proposed this very strict 4-quadrant test.
I love this test because it makes so much sense when you think about the actual nature of bipolar disorder.
It does.
Because treating it isn't like treating a standard illness where you just, push the patient in one direction toward health. You are dealing with two opposite poles.
Right, the highs and the lows.
Exactly. Like, an antidepressant might successfully pull someone out of a deep depression, but the danger is it can accidentally overshoot.
Yeah, which is a huge risk.
Right. And flip that bipolar patient right into acute mania. So, as a true mood stabilizer, an antidepressant fails the test.
Because that teeter-totter effect is the central challenge of the illness. So to pass Ketter and Calabrese's 4-quadrant test, a drug has to prove efficacy in 4 distinct areas.
Okay, lay them out for us.
1, it has to treat acute mania. 2, it has to treat acute depression.
Right.
3, it must provide maintenance, meaning relapse prevention for mania. And 4, it must provide maintenance against future depression.
So it has to work from all sides.
Exactly. It has to push toward the center from all directions at once without ever triggering the opposite pole.
And when you apply that incredibly strict 4-quadrant standard to the pharmacy shelf, the field gets narrow really fast.
Oh, it shrinks drastically.
Like those anticonvulsants we mentioned, valproate and carbamazepine, they fail.
Yep, they do.
They are undeniably strong for bringing down mania, but they are pretty weak when it comes to lifting depression.
Right.
Then you have lamotrigine, another drug often called a mood stabilizer. It fails the other way around.
Right, it's kind of the mirror image.
Yeah, it's fantastic for preventing depressive crashes, but relatively weak at stopping a manic high.
And this is where it gets crazy. Only lithium clears all four quadrants convincingly.
The element.
The element, yes. When you look at decades of randomized trials, it stands alone as the only drug proven to control both poles of the illness comprehensively, both in the acute phase and for long-term maintenance.
Think of a mood stabilizer, like a Swiss Army knife. Most drugs labeled this way only give you the screwdriver or the tweezers.
Right, highly specialized.
Yeah. They are incredibly useful for one specific problem, but useless for the rest. But lithium's the only one that gives you the whole toolkit working in all directions at once.
And if you look at that level of clinical perfection, the fact that it is the only drug to pass this rigorous modern test, you would naturally assume it was the result of a multi-billion-dollar engineering effort by some pharmaceutical giant.
But it wasn't. It was an incredibly bizarre accident.
A literal accident of reasoning. If we connect this to the bigger picture, the origin of lithium in psychiatry shows us just how nonlinear and, frankly, how lucky medical progress can be.
I mean, it's wild.
We have to go back to 1948 to an Australian psychiatrist named John Cade. Now, he was working at a repatriation mental hospital in Melbourne, completely isolated from the major medical centers of the world.
Okay.
And he was operating out of a converted kitchen, of all places.
Wait, I'm trying to picture this. A guy in a kitchen just stumbles onto the greatest psychiatric drug in history. What was he even trying to do?
Well, he was actually testing a completely wrong hypothesis.
Oh, perfect.
Yeah. Cade believed that acute mania was caused by a toxic excess of urate, or uric acid, circulating in the body. So his grand plan was to inject guinea pigs with high doses of urate to see if it induced a state of mania.
Hold on, he was operating out of a kitchen and just deciding what to inject into animals? How did he even choose the compound?
Well, he ran into a practical problem. To inject the urate, he needed a version of it that would easily dissolve in water, like a highly soluble salt.
Okay.
And lithium urate just happened to be the most water-soluble option he had available on his shelf. He chose it purely for its solubility, literally nothing else.
Wow.
But when he injected the guinea pigs with the lithium urate, they didn't get manic. They didn't exhibit any, toxic excitement. Instead, they became oddly lethargic.
Just from the lithium urate?
Yeah. They just sat there completely calm, responsive to touch, but entirely docile.
Which is the exact opposite of what his compound was supposed to do.
Precisely. Now, Cade, being a rigorous scientist, despite, his kitchen laboratory, realized he needed to isolate his variables. Was the calming effect coming from the urate or from the lithium?
Right, good question.
So he tested just the urate, and he tested just the lithium using a different salt, lithium carbonate. And when he gave the guinea pigs the lithium carbonate alone, they became profoundly calm again.
Oh.
The urate had nothing to do with it.
Yeah.
The active calming agent was the lithium all along.
And because this was 1948 and institutional review boards didn't exactly exist to stop him, he just decided to dose himself with lithium carbonate first to make sure it wouldn't kill a human.
It is wild to consider by today's ethical standards, but yes. Yeah. He used himself as the phase 1 safety trial.
Naturally.
It appeared safe, so he proceeded to give it to a 51-year-old patient, identified in his clinical notes as WB.
Okay, who was he?
This was a man who had been institutionalized for years, just locked away in a state of chronic, severe manic excitement.
And the results were staggering, right?
Yeah.
WB calmed down dramatically within days.
Yes.
The effect was so profound, he was actually discharged from the hospital and managed to go back to his old job.
It was an absolute miracle for this specific patient. But from a scientific standpoint, what really proved the drug's efficacy was what happened next.
What happened?
WB eventually stopped taking his lithium on his own, which, is a very common issue in bipolar treatment.
Right.
And when he did, he immediately relapsed and had to be reinstitutionalized. It inadvertently proved that WB hadn't just experienced a spontaneous natural remission. The lithium was actively holding the illness at bay.
Cade published these findings in 1949, and you'd think the medical world would throw him a parade.
You really would.
but nobody really noticed. It took a Danish psychiatrist named Mogens Schau in the 1950s, extending all the way into 1970, to run the rigorous, double-blind, controlled clinical trials that finally proved to the world that lithium prevented relapse.
Right.
Schau is basically considered the father of modern lithium therapy.
And Schau's work was monumental. I mean, thanks to him, by the 1960s, Europe and Australia were widely and successfully using lithium to treat mania.
Yeah.
But here's the crazy part. The US FDA completely refused to approve it for psychiatric use until 1970.
Wait, 1970, more than 2 decades after Cade's discovery. Why? Was there a competing drug in America?
No, it had absolutely nothing to do with psychiatry. It was a tragedy of timing. In the late 1940s in America, right around the exact time Cade was doing his kitchen experiments, lithium chloride was being aggressively marketed in the U.S. as a dietary salt substitute for cardiac patients.
Oh, right, for people who needed to restrict their sodium intake.
Exactly.
No.
Oh, no. I can see where this is going.
It was a disaster. The substance was completely unregulated. Patients were just sprinkling lithium chloride heavily on their food at the dinner table,
Oh, my God.
with absolutely no way to monitor how much of the metal was accumulating in their blood. Several people developed severe, acute lithium toxicity, and some died.
That is awful.
And that regulatory scandal fundamentally poisoned the FDA's attitude toward lithium for 20 long years.
Wait, so a dietary salt substitute scandal in cardiology essentially banned a miracle psychiatric drug for 20 years, leaving American patients suffering while the rest of the world was using it. That is the tragic reality. But, it also highlights something vital for you to understand about this drug. The FDA's fear, while completely misplaced in a psychiatric context, wasn't entirely baseless.
Right.
Those cardiac patients died because they unwittingly violated the central inescapable rule of taking lithium.
Here's where it gets really interesting, because the FDA was terrified of lithium due to what pharmacologists call the narrow therapeutic window.
Exactly. Most medications we take daily have a wide therapeutic index. Like, if you have a headache and you take 3 Tylenol instead of 2, you're usually going to be fine.
Yeah, your body handles it.
Your liver and kidneys have plenty of capacity to clear the excess out of your system. But lithium is entirely different. It must be dosed and monitored strictly by measuring its physical concentration in your blood serum, expressed in milliequivalents per liter.
Let me give you a better way to look at it for everyone listening. Taking a common drug like acetaminophen is like parking a tiny compact car in a massive empty stadium parking lot. You have plenty of room for error, you can drift over the lines, and nothing bad happens. But taking lithium is like parallel parking on the edge of a cliff. One tiny nudge in the wrong direction, and you're over the edge.
That is a perfect visualization. The clinically accepted therapeutic range for lithium is incredibly tight, about 0.6 to 1.2 milliequivalents per liter.
That's tiny.
It is. If you have a patient in a state of acute mania, doctors aim for the upper end of that window, maybe 0.8 to 1.2, to aggressively bring the mood down. For long-term maintenance, they aim for the lower end, like 0.6 to 0.8, to keep the side effects manageable while still preventing a relapse.
But the cliff edge is right there. Toxicity typically starts to appear at just 1.5.
Yep.
And anything above 2.0 is an absolute medical emergency. We're talking uncontrollable tremors, seizures, cardiac arrhythmia, coma, and potential death.
The gap between it's working perfectly and saving your life and it's dangerously toxic is often less than a doubling of the blood concentration.
Which is terrifying.
This is why anyone on lithium has to get routine blood draws. Specifically, trough levels drawn exactly 12 hours after their last dose for the entire duration of their treatment. You cannot just guess. No other common psychiatric drug demands this level of biochemical surveillance.
And it leads to a phenomenon called silent toxicity, which frankly sounds terrifying.
It is, yeah.
Let's say you have a patient who is perfectly stable on 900 milligrams of lithium a day. Their blood level is a perfect 0.7. Then they get some arthritis pain in their knee, and their primary care doctor tells them to take some over-the-counter ibuprofen.
It is a classic clinical teaching case that literally every medical student learns. Ibuprofen is an NSAID, a non-steroidal anti-inflammatory drug.
Right, like Advil.
Exactly. Now, NSAIDs work by reducing things called renal prostaglandins. That sounds like heavy jargon, but here is what it actually means. Prostaglandins are basically the chemical messengers that tell your kidneys how wide to open their filtration valves.
Okay, I follow.
When you take ibuprofen, you suppress those messengers, and the valves in the kidneys tighten up.
So to build on our analogy, If taking lithium is like leaving a faucet running, the kidneys are the drain keeping the sink from overflowing. Taking an NSAI is like suddenly clogging the drain while the faucet is still running at the exact same speed.
Exactly the mechanism. The lithium can no longer be cleared from the blood efficiently. Within just a few days, without this patient ever taking an extra pill or changing their lithium dose, that perfect zero point 0.7 level shoots up into the toxic range of 1.5 or higher.
Just from treating a sore knee with Advil.
It's just from Advil.
And it's not just painkillers.
Not at all. Thiazide diuretics, which are water pills used to treat high blood pressure, can cause it because they pull fluid out of the body, leaving the remaining lithium highly concentrated.
Oh, that makes sense.
ACE inhibitors, another common blood pressure medication, they alter the physical pressure inside the kidney's filtration system, trapping the lithium. Even just simple, everyday dehydration like getting a stomach bug or sweating heavily during a summer workout can cause this silent toxicity. It's why patients are strictly taught to disclose their lithium use to every single doctor, pharmacist, and dentist they see.
Wait, I'm confused. If it's this dangerous, if it requires constant blood monitoring, and if you can poison yourself just by sweating too much or taking ibuprofen, why do doctors still prescribe it?
It's a fair question.
Because modern drugs are these massive engineered molecules designed to fit perfectly into specific receptors with far less risk. How does a single ion, literally just a piece of metal, outperform them?
What's fascinating here is that to understand why it's still the gold standard, we have to look at what it physically does to the brain. And the truth is, despite 75 years of research, its exact mechanism is still a bit of a mystery.
Because it doesn't work like normal drugs. It doesn't bind to a single receptor like an SSRI antidepressant or a modern antipsychotic.
Right.
It's an ion, Li+. It just slips right into the cell.
But we aren't completely in the dark. We have three major working theories for how it operates once it gets inside the neuron.
Okay.
First is the inositol depletion hypothesis.
Okay, you're going to have to explain that one to me like I'm 5.
Think of it like a cellular game of telephone. When a receptor on the outside of a brain cell gets triggered, it doesn't directly cause an action. It starts a second messenger cascade, like a chain reaction of chemicals passing the message deep into the cell.
Got it.
Inositol is a crucial part of that chain. The theory is that in bipolar disorder, this game of telephone is way too loud and overactive. Lithium seems to deplete inositol, essentially dampening the signal. It cuts the wire when the noise gets too loud.
Okay, that makes sense. Dampening the overactive signaling. What's the second theory?
The inhibition of an enzyme called GSK3 beta.
GSK3 beta.
Yes. This enzyme is deeply involved in neuronal plasticity, which is how our brain cells grow, adapt, and prune their connections. It also regulates how our genes are expressed on a daily circadian rhythm.
Okay, and how does that tie into bipolar?
Well, in bipolar disorder, these rhythms and adaptations seem to be completely dysregulated. Lithium steps in and inhibits this enzyme, slowing it down, which allows the brain to stabilize its daily rhythms.
Interesting.
And this mechanism is actually so profound that GSK3 beta is a major research target right now for Alzheimer's disease, completely outside the realm of psychiatry.
That is wild. And the third theory is the one that completely blew my mind when I read the sources.
The neuroprotective effect.
Yes. Because for decades, the cultural stereotype has been that lithium is just this blunt, heavy sedative, that it chemically straitjackets a manic patient into submission.
That is perhaps the most tragic misconception of all. We used to think it just numbed the brain. But modern MRI studies show the exact opposite is happening. Long-term lithium users actually have increased gray matter volume in their brains compared to untreated patients.
It's actually growing the brain. How?
The drug physically increases the production of something called brain-derived neurotrophic factor, or BDNF. Think of BDNF as like miracle-grown or fertilizer for the brain.
Okay.
Untreated bipolar episodes, the severe manias and massive depressions, actually cause structural toxic damage to the brain over time. Lithium isn't sedating the patient, it is actively healing that structural damage.
That is incredible.
It is structurally regenerating the neuronal networks. Patients on a properly dosed, stable regimen don't feel sedated. They describe a profound relief of finally returning to their normal baseline personality.
So we spend billions synthesizing complex molecules to target exact receptors, and yet scooping the lightest alkali metal off the periodic table is outperforming them in literally growing gray matter.
Yeah, pretty much.
But given this incredible neuroprotection, How does lithium stack up against the newer drugs today? Because obviously taking a pill that requires no blood tests is way more appealing to a patient.
And that is the modern clinical debate. Since the 1990s, anticonvulsants like valproate and atypical antipsychotics like quetiapine have heavily eaten into lithium's market share.
Right.
They are often faster acting for bringing down acute mania, and crucially, they don't require you to go to a lab every few months for a blood draw. For a busy, overworked psychiatrist and a hesitant patient, that convenience is highly appealing.
But lithium has one unparalleled superpower that those newer, easier drugs do not clearly share. And this is vital to understand because bipolar disorder affects 1 to 2% of the global population, and it carries an incredibly high mortality rate.
Yes, it does. Lithium is uniquely, definitively effective at reducing suicide risk in bipolar patients.
Wow.
Extensive comparative effectiveness research, like the sweeping meta-analyses synthesized by Dr. Andrea Cipriani, has repeatedly confirmed this. It lowers the suicide rate in a way that the newer drugs simply cannot match.
So what does this all mean for a patient today? It creates an agonizing clinical tension. You are balancing the daily burden of blood tests, the very real risks to your kidneys and thyroid over decades of use, against the unmatched, life-saving suicide prevention of this old, unpatented element.
And because it's cheap and off-patent, it is globally accessible, which is a massive lifeline for lower-resource health systems.
Definitely.
If you want to deeply understand the personal human stakes of navigating this balance, Kay Redfield Jamison's memoir, An Unquiet Mind, is essential reading.
Such a good book.
She's an esteemed clinical psychologist who suffers from severe bipolar disorder, and she relied on lithium personally to save her own life while simultaneously researching it professionally.
She writes so powerfully about fighting the side effect burden versus the sheer terror of relapsing into madness. And, we've talked about the physical risks of the drug, but the historical risk, the medical panic of the 1970s, shows us how badly we can misinterpret data when it comes to this drug.
This raises an important question about how early, poorly controlled observational data can terrify the medical community and distort treatment for decades.
Right, the pregnancy data.
Exactly. In the 1970s, researchers created a register of lithium babies. Based on early reports, it suggested that women taking lithium during pregnancy had a massively increased risk of giving birth to a baby with a rare, severe heart defect called Epstein's anomaly.
Which naturally caused the medical community to panic. Doctors started reflexively pulling their pregnant patients off lithium overnight to protect the baby.
But abrupt withdrawal of lithium is incredibly dangerous. It precipitated severe, life-threatening manic relapses in these women during their pregnancies.
That's awful.
Decades later, much better controlled, large-scale studies came out. They found that while the risk of Epstein's anomaly was real, it was much, much smaller than originally believed.
How much smaller?
Well, the baseline risk of this defect in the general population is about 1 in 20,000 births. With lithium exposure in the first trimester, it increases to about 1 in 1,000 to 2,000.
Okay, so it's still an elevated risk, but it is absolutely not the near certainty that clinicians feared in the 70s.
Right, it's a textbook case of bad data causing harm. It reminds us that the risk of the untreated illness, severe mania, or suicidal depression during pregnancy is often far higher and more immediate than the statistical risk of the medication.
The medical community has a long history of jumping the gun with bipolar disorder, which perfectly illustrates how much of treating this illness relies on clinical judgment rather than, black and white biological certainty. We've been researching this for 75 years, and there was still no blood test for the disease itself. No brain scan you can take to get diagnosed.
And people have certainly tried to find one. There was a famous, highly publicized failure regarding this in 1987. A geneticist named Janice Egeland published a massive study in the journal Nature.
Oh, the Amish study.
Yes. She claimed to have finally localized a specific gene for bipolar disorder to chromosome 11 by studying an old order Amish family tree with a high rate of the illness.
The scientific world must have been thrilled. They thought they finally had the genetic smoking gun. Like, oh, we can just test for chromosome 11.
They were ecstatic. But within just a few years, as more family members in that Amish community grew older and were diagnosed, and as the data was rigorously reanalyzed by other teams, the genetic linkage completely fell apart.
It just didn't hold up.
No, couldn't be replicated. Bipolar disorder isn't caused by one neat, single gene you can test for. It's highly polygenic, involving hundreds of tiny genetic variations and environmental factors. The Amish study became a major cautionary tale for psychiatric genetics.
Which means, to this day, diagnosis remains purely clinical. You sit in a room with a doctor, they carefully observe your history and your behavior, and they decide if you meet the criteria for bipolar hast or bipolar 2.
So when we look back at the whole picture of what we've covered today,
Uh,
we started with a functional myth, the idea of a mood stabilizer as a neat engineered chemical category.
It's not. It's just a label applied to anything that passes that brutal four-quadrant test, a test really only lithium masters. We went from John Cade's bizarre guinea pig accident in a converted kitchen, guessing with water-soluble salts, to a 20-year delay caused by a cardiology salt substitute scandal.
Yeah, quite right.
We learned that managing this drug is like parallel parking on a cliff edge because of that narrow therapeutic window, where a simple Advil can clog the kidneys drain and cause toxic buildup.
And despite modern medicine's push for fast-acting, easily prescribed, highly engineered antipsychotics, lithium remains a vital first-line option simply because it saves lives. It heals the structural damage of the brain, growing gray matter, and it prevents suicide in a way nothing else in our arsenal does.
It is an incredible, almost unbelievable journey for an element that was literally forged in the Big Bang. Think about that for a second before we go. Lithium is the third element on the periodic table.
Right.
It is just one single proton away from being inert helium gas. And yet, this incredibly simple piece of stardust can profoundly organize something as impossibly complex as human consciousness, behavior, and mood. It really makes you wonder, what other basic elemental building blocks of the Earth might hold the secrets to our neurobiology, just waiting for the right researcher in a kitchen somewhere to make a lucky mistake?